the NHS is going to need another, what was it, £88 billion over the next 50 years, which would be a 2% a year increase every year for 50 years, isn't going to happen. There isn't the money in the system. We have to look for new solutions. We have to reboot this conversation, I think, about public-private partnerships. We need a new narrative so that the private sector can play its part in addressing that challenge. I think the private sector itself has got to be more confident, own the discussion, and contribute at the top table. I think we're talking in the past tense now, because I think those kinds of deals, we're not going to do any more of those kinds of deals. And it was more, I think, naivety on the part of the people on the public side who were doing those deals, and they weren't always doing them very well, as we know.
I don't think there is such a thing as a good PFI deal, because I think we all have a vested interest in this. We're all taxpayers as well. And if we knew now what the burden for all of us as taxpayers will be from the NHS, for example. In fact, the Department of Treasury only released their figures not long ago. They're releasing all their PFI figures across all the areas from health and education, etc. But the Department of Health is the biggest borrower of PFIs as well. The debt is over, what, 350 billion across all of those PFIs. And actually, in terms of constructing every hospital that we have at the moment, the 100 or so, it only costs about 57 million or so. So really, the debt deficit is almost 250 million. That would fund any gap, or pay for the whole of the NHS for the next 2 or 3 years. We get 350,000 nurses, 40,000 consultants, etc. So I think the value choice is about public making decisions in this way. We've been duped almost. If we had a better informed public, and I think it's everybody's duty, us as clinicians, there's individuals in the media, in the press as well, about helping us make the value choices that you're going to rent this building for 25 or 30 years. It's not even a repayment mortgage. It's a rental and it's a lease. At the end of it, you've got to buy it. And if you can't buy it, you rent it off for another 30 years. And where do those profits go? And this is a fundamental problem with public-private partnerships. You have a disequity in the profit and it doesn't work. And that's why R&D works, because there is a shared goal. We want better medicines, we want better access, better health, a more productive population. But if you get a disequity in the benefit, as you have with PFIs, it just doesn't work.
But I think that the other reason why there's lack of trust in some of these things is actually what gets pushed under the guise of partnerships, maybe at the lower level, the sort of noise. So as a charity, we get commercial businesses coming to us all the time going, we've got a product that helps people with asthma. You want to stop asthma attacks. You need to promote our product, don't you? Because that's the part that then we can be in partnership, because we can do a collaboration, because we're all trying to do the right thing. And then when it comes down to it, what they want is to shove our logo on their product and basically send an advert out to all of our supporters. And then you say no, and I'm slightly exaggerating, but I'm looking at my colleagues from BLF who I'm sure deal with the same thing. And it's like, but how can you do this? It's all about partnership. We all want the same thing. And I think, probably healthcare professionals get the same thing. We all want to do best for patients, and then suddenly, basically, a just nakedly commercial deal or something to benefit. And I don't think that happens at senior levels of companies, but I think, to be honest, it's naive and unsustainable when people do that. And they think they may have stopped doing it to healthcare professionals. They still think charities are naive enough to fall for it.
If there's one message I could get across this evening, it's been touched on already, and that's around governance. If you get the governance right, and I'm sure the project that my colleague over there mentioned is built on rock solid governance on all sides, because my own view is anything I would do on behalf of my company, I would want it to withstand the test of the best team in the world in The Guardian poring over every detail of what we've done. We call it the red face test, but I would seriously, anything, I can't comment for the rest of the industry, but and certainly commercializing programs around patients is just not anything where the industry would be. And I think if you talk to our industry association, the ABPI, or even the British generic manufacturers, we're just not in that place. As a pharma sector, we're moving away from that. And in fact, those that don't, we deal with pretty harshly, if I'm honest with you.
I mean, I think this is something peculiar to the NHS. You don't get this in the rest of the public sphere. Look at adult social care. 95% of provision is in the private or voluntary sector. but we don't talk about it in the same terms about a privatised.
But when
social
long-term care of the elderly fell off the NHS in the 70s, it wasn't really debated. Long-term care and dentistry suddenly disappeared in large parts of the country. We didn't even debate it, it just happened. But that was one of the reasons we don't talk about it. It was just presented as a fait accompli almost, wasn't it?
Yes, but interesting whether we would, if that was happening now, whether we'd have the debate.
Clearly, we've had a lot of bad press around drainage of resources from the NHS, from PFI, etc. But really, if you look at advances in medicine, even in your lifetime, in your career, this is why I think the controlled, better regulated, more governed relationships are the key, but not to dismiss them completely.